But I think a lot of patients are scared. I know we're going off on a tangent, but I feel like they don't want to offend their doctor. So it's like they're timid to say, I want a second opinion. Personally, I feel like we should, though, encourage them to get a second opinion.
Welcome to Becoming Virtuosa, the podcast. I'm your host, Dr. Susan Crockett. Today you are listening to episode number 50, Two GYNs, Real Talk. An interview with fellow board-certified OBGYN and the director of the Brooke Army Medical Center OBGYN residency program, my friend and colleague, Dr. Erin Keyser.
Welcome to Becoming Virtuosa, the podcast that encourages you to become your best virtuosa self. Each week, Dr. Susan Crockett goes where the scalpel can't reach, exploring conversations about how to be, heal, love, give, grow, pray, and attune. For the first time ever, she's bringing the personal one-on-one teaching that she shares with individual patients to you on this broader platform. A weekly source of inspiration and encouragement designed to empower you. By evolving ourselves as individuals, we influence and transform the world around us. Please help me welcome board-certified OBGYN specializing in minimally invasive GYN surgery, internationally in the top 1% of all GYN robotic surgeons, a certified life coach, and U.S. News top doctor, your host, Susan A. Crockett, MD.
We have a very fun episode today. This is my very good friend, another GYN doctor. Her name is Dr. Erin Keyser. And so today we are doing Two GYNs, Real Chat, which could get into some really interesting stuff. So welcome, Dr. Keyser.
Well, thank you so much for having me. I'm excited to be here.
You're welcome. I wanted to tell the audience a little bit about how we know each other.
Okay.
So I have met you as the program director for the residency program at BAMC for OBGYN. You're kind of my boss because kind of.
Well, yeah. So in the middle of COVID, when we were not operating, I still had to train residents in surgery. And so I had heard great things about different doctors who worked with you doing their robot training. They said you were a fabulous teacher. So I kind of cold called you and you have welcomed my residents with open arms.
I know.
So I'm so appreciative.
Thank you. It's so fun.
Yeah.
Yeah.
No, they love working with you. So thank you.
You're welcome. Well, it's mutual. And so now that's kind of morphed into them being with me regularly, a couple days a week. And so we've only known each other since COVID.
Yes.
Like
couple years.
Yeah. And honestly, I don't know that much about you other than that you're an OBGYN and you do an awesome job with the residency program. And why don't you tell our listeners a little bit more about who you are and what we're going to talk about today?
Okay. I'd love to. So I am an OBGYN in the military, in the Army. So I guess I need to do my disclosure that the views talked about today are the views of mine alone and not the military or the Department of Defense. But I work at Brooke Army Medical Center. I'm an OBGYN there. And I am also a breast cancer survivor. So
I just found that out today. I didn't even know that.
At the age of 34, I was diagnosed with breast cancer.
Wow.
And so through treatment for that, I became menopausal at a very young age. So, by 35, 36, I was menopausal.
Wow.
And I really struggled with a lot of the side effects a breast cancer survivor faces, despite being a board certified OBGYN. So I kind of became for myself an expert in kind of breast cancer survivorship, and a lot of the side effects that breast cancer survivors deal with have to do with menopause and sexual function. So I've kind of have now like a passion for menopause treatment and sexual health and a lot of those issues. So I really want to advocate for, breast cancer survivors to hopefully get the best care, because a lot of them unfortunately feel like, I'm just going to be miserable for the rest of my life.
That's just not necessary, is it?
No.
So, we've got very different stories as far as menopause goes. I'm on the other end of the spectrum going through menopause myself. And so a lot of my audience happens to be menopausal women or women in midlife transition. My audience is a little wider than that. There are all ages that'll be listening to us, and men also, which I think is important. I think they need to hear the discussions that we're going to have too. And in my practice, since I'm mostly surgery oriented, the sexuality side and the menopausal side affects my patients more like, how do I do surgery on them and still help them remain functional? And as you know, as we were kind of talking, the whole premise for this show about going where the scalpel can't reach, it came out of the idea that we have all these conversations with our patients in the office that are important conversations. Yeah. And I think it's important to bring it here to a broader audience. So this is like hitting straight down that barrel of
well, and with the women now living, into their 80s easily, right, you're going to spend almost half your life in menopause.
Yeah.
And so you need to have a full life, and that should include not being miserable from hot flashes. You should be able to have sex without pain. I mean, all these things.
Yeah, I agree. So I've noticed some things personally. You've been doing this, and you're the one that's the expert. What's the organization?
So it used to be the North American Menopause Society, and they've renamed themselves as just the Menopause Society. And they have great, actually, patient information for providers and patients about menopause. And so if you really want to go to, the leading voice in menopause care, it's the Menopause Society or menopause.org, I think is the website.
We'll find that website and we'll link that below. We'll put it in the links for the show. So patients can go there and find somebody like you, although they can't come and see you unless they're in the military, but they can find somebody like you who is linked into that menopausal society so that they know they're getting the most up-to-date, helpful information as possible, which I think is awesome. So all these years I've been listening to my patients talk about hot flashes and, weight gain and the transition and sexuality and societal things. And now I'm going through it myself. And all of a sudden I'm looking at my body like this experiment. Like I've changed how I eat. I've gone mostly whole food, plant-based. I'm becoming much more conscious about maintaining muscle and, dealing with the hot flashes. But it's also made me so much softer and more compassionate, I think, in dealing with my patients. So I wanted you to talk a little bit about your experience as a cancer survivor and how that impacted you going through menopause and the choices you have made personally for taking care of yourself through menopause, and then how that translates into what you teach your patients.
Sure. Well, I definitely feel like, and you probably relate to this, if you've been a patient yourself, it's definitely humbling, and I think it makes us a better physician, right? Because we can really understand, what our patients are going through, and just the struggles and of just accessing care sometimes can be so challenging.
Yeah.
So I definitely feel like it's humbled me to hopefully be a more compassionate and better provider. And then in addition, I've really tried to, like I said, teach myself to become an expert on like what is safe, what's out there for cancer survivors. And I do meet with, there's a cancer survivor group at BMC, which I try and meet with regularly and try and educate patients themselves too about how to advocate for care. But obviously breast cancer is a huge topic. There's so many things, but in general, when we think about people going through breast cancer treatment, oftentimes it does make them menopausal, and they're oftentimes not a candidate for any hormones because of the estrogen progesterone receptor positivity. But even if it's estrogen receptor negative, oftentimes they usually don't recommend like systemic hormones. So it's looking at other options that are out there. So, Paxil or paroxetine is FDA approved for hot flashes, and that's non-hormonal. It has some benefit.
Yep.
You can always use like gabapentin. And then there's a brand new drug that was just FDA approved like middle of May. And that's called Veozah. And that like targets the thermoregulatory center in the brain. And so it's non-hormonal, and it's supposed to help with hot flashes. I've yet to actually get it in the hands of my patients because like literally it was FDA approved like a month ago. But I know you can go to their website. It's Veozah is a medication. If you Google that, and they will help navigate getting the drug because they know it's not stocked in pharmacies yet because it's just brand new.
Yeah. So this is super interesting because of what you said about the mechanism of action. So a hot flash is actually just a vasospasm. The blood vessel is flushing or dilating. And that's what gives us those embarrassing moments when we're like getting up to speak, and then a hot flash comes along and kind of undermines our confidence in what's going on because it looks like we're like not confident about our speaking, but that's just a vasospasm. So you're saying this medicine is targeting that?
Yeah, it's targeting, like, I'm not going to pretend I'm a neuroscientist, but it targets receptors in the brain at the thermoregulatory center. But you're right. I feel like the hot flashes, I think until you've experienced them, you're like, oh, suck it up. It's a hot flash. You get sweaty. But they can be pretty severe where you actually have to stop what you're doing, which you as a surgeon, if you have to stop your surgery because that is really, affects your quality of life. If you're, a high powered businesswoman and you're trying to give a brief and you're pouring sweat, I mean, that can really disrupt like your confidence and your ability to do your job. And so, yeah, it's easy to be like, oh, it's just a hot flash, use a fan, but they can really disrupt your quality of life if you're having multiple throughout the day.
And through the night. So yes. I see women sleep deprived and they're trying to carry on these high powered jobs and being moms and wives, and they're sleep deprived.
And I think that's part of the theory of why weight gain happens in menopause time too, is because lack of sleep is directly associated with you gaining weight and you not being able to regulate your weight, because if you're sleep deprived, and so if you're having 10 hot flashes a night and waking up sweating and uncomfortable, you're not getting quality sleep.
Yeah, well, that's my problem. I'm sure it's not the food that I'm eating at all. I never overeat or indulge in what I shouldn't. It's totally the sleep. No, actually, I'm a sleep expert. I sleep really well. Okay.
I'm very strict with my sleep. I need my 8 hours.
I know, me too. And I track my REM. I don't have my Garmin on, but I usually have a monitor on that tracks my sleep. And I've got my CGM monitor on, not because I'm diabetic, but I'm monitoring how the foods that I eat affect my blood sugar and being real conscious about that, mindful of that. So I think this topic that we touched on about menopause affecting our confidence in our ability to do work, especially when we're in the workplace with men or younger people who don't understand what's going on, I think that's not talked about enough. No. It's really not. Like our prior generations, our grandmothers, they were put in asylums when they started going through menopause. What'd they call it? The
hysteria.
Hysteria.
Right? Yeah, like the term hysterectomy, where you take out the uterus, was from women were hysterical, and if we took out their uterus, then we cured them.
Yeah. Oh, so I got a funny story. So I went to San Diego last month. We had the Women in Da Vinci Surgery conference.
Oh, fun.
It was so cool.
I love San Diego.
I know, it's so beautiful. So I was so lucky to go. There were 200 women Da Vinci surgeons from all over, mostly the United States, but I met some from Mexico and overseas. And it was not a medical conference. It was about taking care of ourselves as surgeons and lifting each other up and building women in the field. And there was this really funny moment where in the auditorium where we were meeting, one woman stood up and she said, "I'm starting a movement." And we were all like, okay, whatever. And she's like, "No, I'm starting a movement to change the word from hysterectomy because of what it represents." And she told that story. She goes, "From now on, we're going to call it a uterectomy."
Right? Well, every other
gallbladder,
the colon, gallbladder, everything else, it's that organ.
Thyroidectomy.
Thyroidectomy. Yeah.
So officially we're going to support her here. And we're going to
love it. Uterectomy.
Now we do uterectomies. So y'all take note. All right. Back on track. We got a little sidetracked there.
And I mean, really the mainstay treatment for the hot flashes should be hormone therapy.
Right.
So I feel like that's probably the next
topic that we should talk about
is hormones.
So, I've gone through the older days from the WHO study when we were doing Premarin, mostly Premarin and Provera. And then the whole WHO study came out. The pendulum swung in the early 2000s for not doing hormone replacement therapy because of its increased risk for breast cancer and blah, blah, blah. And then bioidenticals started coming out around the 2010s, and people started becoming more engaged in the conversation, but also more informed about the difference between a bioidentical or a bionatural hormone versus the synthetics. And so how about if you help me explain to the audience what the difference is, say, between Premarin and the estradiol that we use now?
So there's bioidentical hormones and then there's synthetic hormones. So bioidentical hormones would be the ones that your body produces. And in our bodies, we produce 3 forms of estrogen. We produce estrone, estradiol, and estriol.
So E1, E2, E3.
Yes. So those are like the 3 bioidentical hormones. So estradiol is the bioidentical hormone that you can purchase and take as like a bioidentical form. And then progesterone, there's natural micronized progesterone, but then there's also I guess I didn't talk about the estrogens. Sorry. So the synthetic estrogens are Premarin, which is made from a pregnant horse's urine. So I totally get why people are like not excited to take that.
Yeah, but it's got like 9 different estrogens in it that are not native to humans.
Yeah, not native to humans. So that's a synthetic estrogen. And that's also what was in that study that you talked about, the Women's Health Initiative, which, raised the concern about breast cancer. And they also used a synthetic progesterone, which is medroxyprogesterone acetate, but there's lots of synthetic progesterones. There's
in our birth control.
In our birth control, there's norethindrone, there's levonorgestrel, there's a lot of them. But if you wanted to do the bioidentical natural ones, it would be like a micronized progesterone and then the estradiol.
Right.
And so, so there's synthetic and natural. And most of the studies were done with those synthetic ones because that's what was available.
Right.
And so I don't think we have good long-term data or studies looking at the bioidentical ones and
we
what
really don't.
They cause. Yeah.
Because it's only been a little over a decade since we really paid attention.
And really now, as we're looking at the data from the studies, we're finding like new things. Like if you start the hormones, closer to menopause, there's probably not that increased risk of heart disease or anything else. And there's lots of benefits to it, right? Like we know it protects your bones. We know it helps with weight gain. We know probably preventative against like diabetes and helps with sleep. I mean, there's all these other benefits. It's decreased risk of colon cancer and uterine cancer and ovarian cancer. But then there's like the slight risk of, stroke or breast cancer or some of those other things.
Yeah. So I love that we're in a time where we have access to them. I wish we were in a time where we knew all of the answers about it. But I love that we're also able to prescribe these things. Most of them are covered under our health insurance.
Yes.
So I wanted to kind of talk about the difference between the cash pay only bioidenticals and then the bioidenticals that are widely available through our pharmacy plans and insurances covered.
Yes. So I feel like there's been this fad of bioidentical hormones where people are creating these little doc in the shops and saying, come test them, we'll prescribe them. But I feel like that's kind of flawed in several ways. One is there's really no reason to test your hormone levels because your estrogen level and my estrogen level may be very different, but it does not correlate with how symptomatic you are. And if I'm not having hot flashes and my estrogen's low, I don't think I need to take estrogen if I'm not having symptoms. So we don't base it on like a number, right? We treat symptoms. And really there's been no correlation. And that's true for testosterone too. I know we're probably going to get into that later, but testosterone, right? Like testosterone levels don't correlate with your sexual drive or your sexual function.
Right?
Yeah. Which is, I know it's like you would think like, well, if my testosterone's higher, I'm going to be horny or this. So there's no point in paying cash and testing for these hormones because there's no correlation with symptomatology. And I'm not going to treat a number. I'm going to treat your symptoms.
I do the same thing. I talk a lot with my patients about how I have kind of a dosing range in mind for them where too much we know is like there's something else going on that I need to look at, or it's just too much. It's outside the range. But within that dosing range, I tend to prescribe to symptoms also. And so I have 4 rules in my office for hormone replacement therapy. And I consider myself pretty basic. Like I'm not doing the fancy compounding and testing and correlating adrenals and all that. I'm a surgeon, but I do a basic amount of mostly starter or refill hormones. So I usually say we want to use the smallest amount for the shortest duration for specific symptoms and choose bioidenticals. Those are my 4 rules. Yeah. And then if it gets more complicated than that, then I need somebody that's got like a functional medicine background or a higher level of education. And I have a nurse practitioner that's doing that right now. And she's a whiz. She's like way above me in all the physiology and helping people if that dosing range isn't working, because there's only like 2 doses of estrogen. And she really gets into all of that. But I think the point that we want to make is that one does not have to be out of pocket.
Correct.
There are bioidenticals, good bioidenticals. I'm taking them. Yes. And I'm using my insurance. And I would if I weren't a breast cancer survivor. And also, I want to mention something else that I do and ask your opinion about this for breast cancer survivors, which is usually when we're dealing with vaginal atrophy or vaginal discomfort during intercourse, I've been taught that it's okay to use a small amount of topical estradiol to help keep the skin healthy, that doesn't get into the bloodstream enough to really increase the risk. And then you can also use estriol cream through a compounded pharmacy. My breast cancer docs that I refer to have cleared that for my patients.
100%.
What do you think about that?
Yeah, 100%. And I use the E-string, which is estradiol vaginal ring. Yes, I feel like ACOG, American College of Obstetricians and Gynecologists, supports that. There's been studies done in like JAMA Oncology. So yes, our hemoncs do support topical estrogen is safe. They have compared the different types of topical estrogen.
They have?
Yeah, and like how much is systemic, and Premarin cream, which is a synthetic, does seem to be more systemic absorption. So I agree. I would stick with like a bioidentical, whether it's like the Vagifem tablet, like the estradiol tablet, or the estradiol ring or the estrace cream, but all of that considered topical shouldn't have systemic absorption and has been no association with like increased risks.
Yeah. So now we're getting into another topic.
Wait, I did want to go back to the bioidenticals because I don't know if we talked about that quite. So I totally agree about cash. So people go to these like doc in the shops and they get like pellets or these like other things which are not FDA approved, and the amount your body actually gets is kind of unknown. And so in a way it's unsafe because you may not be getting the right amount to protect your body or prevent, other cancers. Because if you have too much estrogen, you're at risk of uterine cancer. And if you have too little, you're not treating your symptoms. And so there are FDA approved bioidentical hormones that we talked about that your insurance will cover, that have proven to be safe in multiple studies, and your insurance can cover them.
Yeah. So I'm glad you brought that back up. There's two concerns that I have about those types of setups and the pellets specifically. So one thing that I've seen is I don't like the dosing that happens with pellets because they get a spike up and then the pellets absorb into your bloodstream and disperse. It's supposed to be like 3 months, but for some people it can be longer, and then you have to redose it. So you're constantly getting pellet in it. And so compared to just being on an estradiol patch every day or the same gel dose every day, it's not as consistent. And so when I have patients that I make surgically menopausal, I'll usually put them on an estradiol patch just because it makes it super even. Yeah. And then it's easier to get
actually, that's important. When you talked about the 4 key components about like starting someone on hormones and like the dose you need, but also the route. And I think there's more and more data that a non-oral route, so a patch or a gel or a cream, probably is going to have less risk of blood clots and some other things because it doesn't bypass through like
it doesn't go through the liver. And the liver. Mm-hmm.
Yeah. And so using like a patch or something that's transdermal is probably a better route. Sometimes when I'm talking to my patients, I like say, well, do you have sensitive skin? Some people can't tolerate that. And so then maybe a pill is better for them. And there's even the fem ring, the vaginal ring that has systemic amounts. Yeah. So I think a non-oral is probably less risk.
Yeah, I think there's good data that supports that too. Yeah. This is one place where I would venture off into some compounding, and that is a sublingual troche.
Oh, I haven't looked at that. Okay.
Actually, for some people, if they need like smaller adjustments in their dose, they can put estrogen, progesterone, and their testosterone in a little troche, and it goes under their It's a sublingual. Yeah. So it is transmucosal. It's not going through the gut. It still qualifies as through the skin. So sometimes our skin gets really kind of more keratinized, or it doesn't absorb as well as we get older. Yeah. And so I've used the troche for women whose skin doesn't absorb so well.
I have to look up that.
Kind of interesting. Yeah. And in some cases it may be cheaper just if they're combining them all into one prescription. So that's kind of an interesting thing.
Yeah. And I have no dog in the fight. Like I'm in the military. You can't come see me. So I have no dog in the fight, but it's like, if you want a hormone expert, like don't go to that doc in the shop who they're pushing for their own gain of money, like, which I don't even know if that's ethical, and I would go to the Menopause Society website and find a menopause expert, right? And not just like some person who hangs a shingle and says I'm a hormone expert.
Yeah. And for me, like, people can come see me, but please come see me for your surgery. Don't come see me because you want a menopause.
Yeah. And get a second opinion. I feel like it's hard. Like we're proud people. So it's like, yeah, I could do that surgery. Could I do it through could I do this huge uterus through a minimally invasive surgery? I don't know if I'm skilled enough to do that, but I know you can. So I encourage you all, go get a second opinion from Dr. Crockett if your doctor says you have to have a big incision for your surgery.
Well, thank you. I see that all the time. As a matter of fact, I have patients every week who call and say, how big can you do and still do it minimally invasively?
But I think a lot of patients are scared. I know we're going off on a tangent, but I feel like they don't want to offend their doctor. So it's like they're timid to say, I want a second opinion. Personally, I feel like we should, though, encourage them to get a second opinion. And we shouldn't be scared to say, I like what you say, but can I get a second opinion?
Well, and I feel that way about the hormone stuff. I'm like, I'm very basic here. I know the basic. And if you're having trouble, then I'll send you to see my friends. So we kind of got off on a tangent, but it's a good tangent. And I think I want to go ahead and end this part of our conversation. I think we've got enough to talk about to do a second episode. Would you like that?
Let's do it.
Yeah. I think we're kind of...
I know, we haven't even talked about sex.
I know. Let's talk about two GYNs talking about sex. What could go wrong? What actually could go wrong? Well, thank you for doing this interview with me. It's been so informative for our guests, and I can't wait to hear the second part. So stay tuned. Thanks for listening to this episode of Becoming Virtuosa. To learn more, come visit us at drcrockett.com. That's drcrockett with 2 T's.com. Or find us on YouTube for The Dr. Crockett Show. If you found this episode helpful or think it might help someone else, please like, subscribe, and share. This is how we grow together. Thanks, and I'll see you next week. Love always, Sue.